The first speaker we're going to hear is the chair. She's the chair of Merseyside Against Blood Cancers. She's called Abby, and she's there.
I'm Abby Pointing, and I am hugely privileged and extremely honoured to chair this fantastic charity. We're called Merseyside Against Blood Cancers. That was set up about 11 years back. Our aims are to support blood cancer patients. We fund research, and any of the bigger research projects such as funding PhD we work jointly with the Northwest Cancer Research. And we fund training as well. We are a small charity, but huge, big ambitions.
We're going to start off, though, with somebody a long time ago that he was diagnosed with blood cancer. And he told the story himself, but the point is, it's not a very good story. Frank.
In 1998, excuse me, I've got a prompt at the side. 1998, I was taken ill. My doctor and my company doctor said I was unfit for work. After a load of medicine, they referred me to Manchester Royal, and the consultant diagnosed I had ME, post-viral fatigue syndrome. After about 4 years, I developed this thing on the side of my face. So my doctor referred me to the consultant at Wigan Infirmary. He said, you need to have it removed. So I had this thing on the side of my face removed. And then they turned around and said, we'll have you back in a month and give you the results. 5 months, they still hadn't been in touch, so I rang up. So I made this appointment, and there was one fellow in the room, and he just said to me, do you want the good news or the bad news? I said, beg your pardon. He said, well, the good news is your hearing's okay. I said, pardon? He said, yeah, I had a hearing test. I said, that was 3 years ago. He said, well, your hearing's all right. I said, what's the bad news? Just out of the blue, he said, right, so you've got cancer. That was it. That was the end. I just went to pieces. I can't remember driving home or anything. There was no one in the room with him. And I got home, and the boss came in, the notice at the boss, came in, and she said, what's up with you? And I explained to her what was wrong. It's unknown to me. She's on the phone next day. They turned around and said, he shouldn't have been in the room on his own. There should have been 2 other people there, an advisor and such a person. I've seen a consultant, Dr. Banami, her name was, and she was wonderful. I remember putting a hand on my arms and she said, don't you worry, I'll do the worrying, get on with your life. So after 2 years, I think maybe a bit less, she said, I'm retiring. 2 more visits. I've seen 2 different consultants, and both of them turned around and said, we're not permanent, we're only locums. Nothing happened, so after 5 months, I rang up, got in touch with a rude lady. I would say, it's unbelievable. She was so abrupt with me, and she said, why, have you got a problem or something? Why are you ringing up? I said, pardon. I said, I'm having treatment. I said, I want to know what's going on. And I was so upset, I went to see my GP, and he said, just turned around and shrugged. He says, do you want to go to another hospital? I said, yeah,Id like to go to Liverpool Royal. So I went to Liverpool Royal and seen a young doctor called Dr. Calaconda. He's now Professor Calaconda, and he's grown old with me. Anyway, long story short, I had 2 lots of chemotherapy. Then I was on a trial drug which was Brutinib, and I was on that for about 6-7 years. I stopped taking it in last September, and I was fine. This latter couple of months have gone downhill, so I'm back on treatment. And his staff and his guardian angels, as I call them, they're brilliant. Basically, I look forward to having a friendly face saying, hello Frank, how are you? And I can't praise them enough. They're absolutely superb, and thank you all for all the good care you've given me.
So could that happen today, is the question?
Well, I hope the communication aspect wouldn't happen today. I'm not saying it never happens, and I think that's why we've been looking at what education resources and how we can help. We know that a lot of them are vague presentations, and it's how do we filter those through. We see a lot of patients who are tired all the time. A lot of the symptoms, mimic things that we see very commonly, particularly back pains, thinking about myeloma, and how do we differentiate that from the people that we do need to worry about? What is it that makes this slightly different? So, thinking about myeloma, the presentation of back pain, how is this different from somebody's got chronic back pain, how is their back pain different at the moment? You know, is it keeping them awake? Are there things that just don't seem right? They have three strikes and you're in. You've seen back with 3 times with the same thing. You know, something else is going on here. And the resources that we're working on, so it was designed essentially for GP registrars and foundation trainees. So we're doing a suite of resources that are going to sit on the Cancer Academy. Although we're aiming at GP registrars, the plan is that everybody's going to have access to them. So for the blood cancers, there'll be a dedicated section with some sort of easy resources, so things like Red Whale and Gateway C, because there's actually a lot of good guidelines out there, but it's having them at your fingertips. The other thing that we've been working on is clinical templates that work within our computer system, because a lot of the time it's, you know, patients come with lots of things and sometimes, you know, things overlap. And how can we quickly get access to the guidelines while the patient's with us, so we don't let them leave before we realise we need to be doing other bloods or other investigations. Say a patient's presenting with something that we might be thinking, oh, could this be a symptom of blood cancer? You know, what does the guideline tell me? If I need to do bloods, what bloods do I need to do and how quickly do I need to do them? You can actually open up these templates while the patient's with you, and they actually link into our clinical system. And the other really important thing, I think, is safety netting these patients, because, you know, what we don't want to happen is, you know, you were saying about how, you know, you were meant to get your results within this amount of time and then it was so many months down the line. It's the ones in between, it's the slightly borderline blood results that, you know, might not be a worry at the moment, but, you know, we want to repeat them in a month to check the trend, and they might need a referral at that, but making sure we don't lose them in that. You've got to be careful that you don't shoehorn someone down the wrong pathway that ends up taking longer to get there. I mean, we're lucky we've got things like the vague symptom pathway, which I think you've got in all the areas in the region now. So even if you don't maybe think it's necessarily clearly a blood cancer, you know, I don't think necessarily it's a wrong thing to go down vague symptom, because that might pick up something that's a lymphoma on a scan.
Was early diagnosis important, and has it become more important, and are you getting more early diagnosis now?
I think early diagnosis is important. The issue of how long somebody has waited is overstated sometimes. I worry that when I look at the referrals now, sometimes, you know, people just take the 2 things that are going to get the patient a 2-week referral. We do get inundated with patients who probably don't need to come on the 2-week pathway. And what happens is that you're blocking a lot of patients who really need to be there. The other big problem is, even since, well, I've been in Liverpool since 2008, the machines have become extremely sensitive. So let's take a paraprotein, an IgM or IgG level. Even 5 years ago, the machine probably wouldn't have detected the level that it's detecting now. So what's happened is the bar at which you refer has really dropped. And so that then increases the number of patients who are then referred. And so a lot of them don't need to, because it frightens patients. There's nothing worse than a patient receiving a letter to say, right, you have an appointment in Clatterbridge. I had a patient last week who turned up with 8 people from his family because they were just petrified. And the problem, unfortunately, the information that they were given just, you know, needed to be managed.
So we've changed the patient information letter, so anybody who's referred down a cancer pathway, because obviously that covers not just blood cancers but every type of cancer, that they might have a telephone appointment. So for our lower GI pathway, a lot of patients initially have a telephone appointment. It explains the different ways that might happen, and obviously that the majority of patients that we refer, because you've got a 3% threshold, haven't you, of detecting cancer, the majority of patients we refer won't have cancer. However, we do have to warn that it's a cancer referral, because I talked about a case that they dealt with where a patient presented with a neck lump, saw the GP, and essentially was reassured very quickly that this wasn't cancer. And they didn't hear anything else after that. They'd got so worked up that they thought this was cancer. They heard the word, it's not cancer. I think it was about probably six months down the line that they re-presented, and they went on to have a lymphoma. So I think the way we communicate is important, and it is a real fine balance between not wanting to frighten patients but also being honest with them.
In a 10-15 minute consultation, you might not be able to counsel them thoroughly at the very end, because you're like trying to rush and do the referral at the same time. But absolutely, I think it's really important to give them a letter to go with that they can go home, read about, and then they know exactly what they're being referred for, just as an extra safety net. It's really important.
The one that really clogs up our clinics is night sweats.
Yeah, I think we're in a unique position. We have symptom-based referrals. We also have referrals which if someone's lymphocyte count is 8, the lab has automatically triggered them to have flow, which has confirmed CLL, which has come back and someone's gone, you've got a leukemia, and then we actually look at it and go, they don't need to be seen for 6-8 weeks, and they have no information between about what that leukemia is, so they come into clinic like thinking it's an acute AML or something like that, and then we have to really say, actually, you might not never need treatment, you might only need treatment in a few years, and the treatment's really good. And I think there's a lot of automatic stuff that comes back, and then you just get a report that says CLL, for example.
How do we help with that, and how can we look at maybe the labs helping with some comments on what they put on reports? I mean, I know the eye system is different in different areas, but actually, you know, making a suggestion about this might be more suitable for advice and guidance actually on the report.
Is that automatically done then with the immunoglobulins?
So let me tell you a story about an novel like this. So if you see an IgM paraprotein, it is never going to be a myeloma. Myeloma never has an IgM paraprotein. Say the G, A, occasionally, very extremely rarely D, which I've probably seen 2 cases of. IgM paraprotein is always, if it ever progresses, which it never does, very rarely does, because everybody above the age of 70 may end up, if you screen everybody, 80% of the population is going to have an IgM paraprotein. And that will, if it does progress, it progresses to a lymphoma. So I saw a patient, somebody who was discovered to have IgM paraprotein, and the IgM level was 2.2, the upper limit of normal is 2. And the serum paraprotein, IgM, was 2.1 4 years ago. At the time, it was thought by whoever saw him that they didn't need to worry about this. But then that same patient then went back, they're now in a different practice, 2 weeks ago. And unfortunately, somebody in the practice said to them, "Oh, you need to have seen a hematologist when this was first discovered, because you have bone cancer." So one time she was told she has bone cancer, and then 2 days later she was told, "Oh, it probably is not bone cancer, but you've got blood cancer." So I know how that came about, because the minute you say paraprotein, and correct me if you're wrong, first thing that goes through your mind is myeloma, right? There's IgM paraprotein, especially if it's that level, it's never going to become.
Does the lab put a report?
Because
Because that's the type of thing we would need as a lab comment.
The lab reported small, unquantifiable paraprotein.
And I think even if it's just repeat or because we don't actually see that many
So I think
paraproteins.
That's the kind of thing that would be helpful, wouldn't it?
We need guidance,
Guidance from a lab.
The problem is that this patient, and then we saw that somebody in our practice saw the referral, so this is only 2.1, has only gone up by 0.1 in 4 years, so they gave a 3-month appointment. But the patient in primary care was told you might have a bone cancer or a blood cancer. So they've been sitting there, and they were absolutely petrified. So I think we need to find a balance. We have to find a better way of maybe engaging to see that that doesn't happen. If it's 2, we don't treat them until it gets to 30. Okay, unless they have symptoms or they have big nodes or spleen. So if it's less than 10, it is, to me, that's not urgent.
But they would like the MGOS, so...
It is MGOS.
Yeah.
If it's just starting to get about 10, and that, you're probably better off sending them in. And also, I think when it's MGOS, we really need to say to them, this is pre-cancerous. So if you get an 80-year-old and you're telling them, 1, it becoming a myeloma lymphoma is 10% in 10 years. But at that point, maybe another 10 years before they need treatment. Okay, so I think there needs to be some work done. I do think we need to redo the referral forms and also have some literature out there.
Where would be a good resource for us? So if we've got these results back, that we can go and refer to say, well, actually, this is more likely an MGUS, I can do a routine haematology. Is it Haematology UK? Or?
Our guide, like all the haematology guidelines, there's a website called HaemoBase.
Okay.
And it stratifies by disease, malignant and non-malignant, and has links, has summarised the BSH guidelines and has links to them in detail.
I want to get it back to the patient because we have another patient here Kaylee.
Yeah, in 2011, I was diagnosed with non-Hodgkin's lymphoma. I was 18 at the time. My symptom that I presented with, it was a small pea-sized lump in my upper chest. I made an appointment with the GP quite quickly. I was seen the following week, and I was met with some uncertainty about what it was, and they were asking me if I banged myself. And it was quite an unusual place, and it didn't have any pain either, and I was adamant I hadn't banged myself. So they were a bit uncertain, and then I got a colleague to come in and have a look, and they were still very uncertain and and ahhing, and I could just sense that it really wasn't taken very seriously, or maybe not taken seriously, but not the severity it wasn't maybe considered. So I was actually dishonest and told a lie, and this might be intense to some people, but I actually said to them I had breast cancer in the family because I knew I needed to be seen. They agreed then to the referral, and I was referred to the Linda McCartney Centre. At the time of going to the GP, I thought that the lump was my only symptom, but it weren't. The main symptom was excessive tiredness. So I was 18, I'd had a full-time job, I was going out on the weekend, having late nights, but I was really tired some days. I'd come home from work at 5 o'clock, and sometimes I'd get into bed and I'd stay asleep till the next morning when my alarm went off for work. I think the longest time I slept was about 19 hours. And those days I was at work and I could feel my eyes rolling, and I actually fell asleep on the desk a few times as well. And I think another symptom I had was night sweats, but I didn't realise it was night sweats. I was shouting at my mum for putting the heating on at night. All the jigsaw didn't come together till after I was diagnosed. But when I was at the GP, I weren't asked any other questions. I weren't asked any questions outside of what I presented with. I wasn't asked about any other lifestyle issues. If I was asked, maybe I wouldn't have felt like I needed to tell that lie. So I went to the Linda McCartney Centre the following week, and they done a mammogram and a ultrasound, and on the ultrasound it showed up that it was like a small dark circle. So they'd done a fine needle aspiration, and I found out on the day that the cells were abnormal, but didn't know specifically what the abnormality was. So I had to come back in 2 days' time for a biopsy. And then I got the results a week later, and then that's when I was diagnosed with anaplastic lymphoma, is it? Yeah, anaplastic lymphoma. All in all, it was 3 weeks from the point of me finding the lump to diagnosis. It was 3 weeks, so it was quite quickly. It's because I was a young person. I was linked into other charities with other young people. We've done a lot of peer support events, and from them, I spoke to so many people that weren't as lucky as me to get a quick diagnosis. Some other young people had been to the GPs 6 times plus, and I think that because we were young, no one ever thinks of cancer. It's not going to be sort of the first port of call. But by the time I did get diagnosed, my symptoms did progress quite quickly. I started getting lumps in my neck and in my face, so my nose was quite blocked, and my mum was going to buy nasal strips to try and open up my airways because I thought it was a cold.
I was going to say, I mean, I think, you know, the experience, I think you being quite stubborn has obviously pushed you kind of through. I don't think that's maybe the normal experience for everybody for that diagnosis so quickly. Mm-hmm. Should it be the gold standard? Maybe. I don't think that's something that, you know, will be something that happens. I certainly hope that practices do take things on board, take those symptoms on board, and certainly in my practice, I think, would I have necessarily referred you as quickly as you were? Hand on my heart, probably not. And, and the thing is, you were in the right.
Yeah.
And but it's certainly something I would have, you know, I think as standard, and I think probably for all of us, I would normally say to patients, if this doesn't go within a certain period of time, kind of 3-4 weeks, come back and see me, and then we'd investigate and start. So I would hope that there's that inbuilt safety netting.
I was diagnosed on a Friday, and that day they took me up to the ward, showed me where I would be, and I was back in on the Monday. I had my first chemotherapy, so it was quite a rapid treatment that I needed. But can I ask you, if you knew about the lump, knew about the excessive tiredness and the night sweats, would you redo the referral then? Because if I was asked them questions and you knew all that information together.
I think it would be. I would be more prone to investigate it sooner, and whether or not I would have done the referral or whether or not I've arranged bloods and ultrasounds first. Yeah. I think that would have been probably the route I would have gone down, purely because, as kind of my colleague said here, is what I would want to do is be able to it's quite difficult to explain to a patient. I feel that when I'm referring a patient, I need to be able to tell a story and say, this is what the patient's come in, this is what we've done, this is what I found, and this is as far as my expertise go, and then they can make the decision as to, you know, this is something which we need to pick up on and run with quickly, or this is something that can wait a little bit for time.
I think with lymphoma it's obviously more difficult in that, you know, with a potential breast lump, it's, you know, you're suspecting breast cancer, and particularly in somebody that's young, you would then treat them for so long or review them back depending on when they were on the cycle. So I suppose sometimes you might be less thinking about the other questions, but again, that's an education point, isn't it? That with a breast lump, you wouldn't necessarily be jumping to think lymphoma, so you might not ask those other questions, which actually in your situation was very relevant. And I suppose you ultimately often have to go down a non-haematological referral route initially, because you need to get to the quickest route to get a biopsy. So depending on where the lump is, you know, neck lumps, trying to avoid doing an ultrasound. If it's persistent, send them to, you know, suspected cancer ENT so they can biopsy it to see if it's a lymphoma or a head and neck cancer.
For me, I have completely normal bloods. If you're suspecting that someone has got a blood cancer, if you're really suspecting it, should you wait for the bloods, or should you just do the referral? Because you'd still see them with normal bloods, wouldn't you? It's getting that balance between over-referral and under-referral.
Because does that depend on the type? For leukemias, my understanding is if you've got a normal full blood count with leukemia, it's very, very unlikely that you've got blood cancer. However, obviously with a lymphoma, you know, you can have lymphoma and have a normal blood count.
If it's a lymphoma, if it's in the lymph node, and it's not involving the bone marrow, your blood counts are going to be completely normal for a very long time, even sometimes through treatments. So I would, the only time the blood count itself probably indicates something is when somebody's got an acute myeloid leukemia or lymphoblastic leukemia. That's quite rare.
In my case, I went for a flu jab, and the nurse just asked me a question. She says, so how have you been, Abila? And I had sweats and tiredness and all that. I said, well, I've had 2 very busy years because I was working in Abu Dhabi. I was house sheriff for a year. I would have put it down to that. So the nurse says, no, let's send you for blood tests. So she asked the GP referred me, and within, I think, about a few days, I was in the hospital. If it wasn't for the intervention of that nurse, I don't really know, when I would have put it down to, oh yes, I've got flu, I'm not feeling very well, I'm just run down, I'm too tired. So I just wonder whether there's more work needs to be done with other staff in your GP practices as well.
Yeah, I mean, we look at something called making every contact count, so that's we are doing work to realistically go through sort of every cancer type might not be possible, but just a general question of, you know, well, how are you? And they might know that person better, and it might then be just prompting to say, I think it's probably worth you booking in with a GP.
Well, there's 2 things I think, even if you take away from today, it'll help us and it'll probably help you as well. One is IgM paraprotein. What do we do with an IgM? If it's, say, 3 or 4 or even 5, you repeat it in 2-3 months, and then I think the trend is important. So in 6 months' time, if it's doubled or whatever, then you definitely need to refer them in. If it's staying steady, you just repeat it every 6 months or 12 months. And if it's not changing and they don't have any other symptoms, then you can just watch it. The other thing is CLL. I think you all probably come across the term monoclonal lymphocytosis, and that is something that's only appeared in the last few years, and that's a pre-CLL condition. And again, the lymphocyte count is like 4 or 5, they're just about normal. I think the first step we need to do is the referral forms definitely need looking at.
I think as well, sometimes it's patient's expectation, so if you feel like the referral needs to come in, because it's better to, I'd say it's better to put it in and it not be something to worry about, but even if after today or from looking things up, you can explain to the patient that it's probably nothing that they need to worry about, just that expectation of not needing a 2-week wait and you might be seeing follow-up, even that makes a massive difference.